Hello, overcomers, and welcome to this episode of Connect Ovar Coffee. I'm Runsi, the founder of Overcome, and today I'm joined by one of our greatest champions, and our advisory board member, Dr. Marta Crispens. So, Dr. Crispens is professor and director of Gynecologic Oncology at Vanderbilt Cancer Center, and as Overcome's advisory board member and one of the top global experts in the field of ovarian cancer, Dr. Crispens is passionate about serving all our overcomers. And as her patients say, Dr. Crispens represents compassion at its finest. We have a lot to chat with her today about all things ovarian cancer, with a particular emphasis on recurrence, which we know is top of mind for most of our overcomers. So grab your favorite beverage or coffee. I have mine, which I'm doing water only today, and join us for this thought-provoking conversation. And if you have any questions as we go along, please type in the comment sections below and we'll try to get it addressed post the discussion. So with that, a huge welcome back to you, Dr. Crispens, to this episode of Connect Over Coffee. Always such a tremendous honor to have you with us.
Well, thank you, Runsi, for that lovely introduction. Appreciate that very much. And thanks to you for all the great work that you do to support ovarian cancer patients, ovarian cancer research.
Thank you. So again, as I always have, a lot of questions. So before we get started on the details, we know that while current treatments such as surgery and chemotherapy can initially shrink tumors, but in many overcomers, in most cases actually, they experience a recurrence with the tumors developing that drug resistance. Can you tell us why this drug resistance happens and what should our overcomers know about this?
Yeah, well, and I think actually in that context, it's really important to kind of parse out ovarian cancer now as many different diseases. We used to approach ovarian cancer as a monolithic disease. Everybody had the same disease, everybody got the same treatment. And we understand that ovarian cancer is even if we want to just confine this to epithelial ovarian cancer, the most common kind of ovarian cancer, we actually know that that is multiple diseases with multiple molecular underpinnings. And so, for example, we used to treat low-grade serous carcinoma and high-grade serous carcinoma in exactly the same way. And as we have come to understand that low-grade serous carcinoma is a super different disease, we understand that it needs very different treatment than high-grade serous carcinoma, which would be the most common kind of epithelial ovarian cancer. But I think even in the high-grade serous carcinoma group, we are beginning to understand that that's not a single disease with a single set of molecular drivers, right? Mm-hmm. So on one end, we have the 10 to 15% of serous carcinomas that are associated with a BRCA1 or a BRCA2 family mutation, right? For those patients with the advent of PARP inhibitor therapy, we've seen really much better outcomes, with the years of PARP inhibitor maintenance with olaparib. Whereas if we look at patients, then in the middle, we have patients who have, so BRCA1, BRCA2 cause malfunction of the ability of the cancer cell to repair DNA damage in a very profound way. In the middle, we have patients who have other causes of DNA damage repair deficits who kind of have middle outcomes. And then that gets you half of patients when you get all of the patients who have these dysfunctions of DNA damage repair. Then you have this other half of patients with serous carcinoma whose cancers don't have that dysfunction of DNA damage repair. And I think one thing that I'm being very careful when I meet new ovarian cancer patients is to tell folks that until we know what your BRCA and HRD status is, we actually can't give you a really great prognosis in the way that I used to be able to say. Unfortunately, we know that X% of all ovarian cancer patients are going to recur. So we want to really parse that out more finely. In the end, why does any cancer recur? The cancer recurs because even if we get a complete remission, there were a small number of cells left behind that were resistant to our initial therapy. And unfortunately, it probably only takes one. There are lots of theories about why this is, but just statistically, if you have a large number of cancer cells to start with, millions of cancer cells to start with, even if you treat with 2 drugs, 3 drugs, 4 drugs, however many, and we usually treat with 2 drugs with ovary cancer, no indication that more drugs is better, to be clear. But there's just statistically, with millions of cancer cells, a high likelihood that at least one of those cells is going to be resistant to the 2 drugs that we give from the beginning. That's unfortunately just statistics. On a more finer point, in terms of a molecular basis, there are tons of reasons for drug resistance that have everything to do from, you know, how the drug is internalized into the cell, or how it might be removed from the cell, how it's metabolized, just a whole lot of different ways that drug resistance occurs. And there are people who are working on trying to target those resistance methods.
Okay, thank you. So, since we last talked on this Connect Over Coffee, Dr. Crispens, I think back in 2024, what has changed in managing recurrence in ovarian cancer since you and I met last year?
Yeah, so I think things that we've looked at in ovarian cancer over the last year, a big thing has been and I honestly I should have looked at I should have looked at our talk, but since over the last year, things that we've been focused on are the development of antibody drug conjugates, which I think we
Yes.
did talk about last year,
Mm-hmm.
right?
Yes.
And also, so things like Elahere. Um, but also, I think a lot of movement in the area of trying, not so much that we have these drugs yet, but trying to identify the drivers of immunotherapy resistance in ovary cancer. That has been a big target of research. And then again, looking at other targeted therapies for other types of ovary cancer. So things like trametinib in low-grade serous carcinoma. So thinking about ovary cancer again, not as a homogeneous disease.
Thank you. So, I was recently reading that preclinical studies have shown that combining the IL-4 and the PD-1 inhibitors may improve outcomes for ovarian cancer patients. This was just a few days ago that I was reading. So, can you tell us a little more about what these inhibitors are, what they do, and how they may improve the outcomes for our overcomers?
Yeah, well, that's a great example of one of those places where researchers are trying to figure out how to leverage inhibitors. So PD-1 and PD-L1 inhibitors have not worked in ovarian cancer, despite thinking that they should.
Yeah.
But they've been super disappointing. And so people have looked for why. The immune system is enormously complicated, and there are so many things, so many factors that ramp it up or ramp it down. And this is important because we need to be able to respond to bacterial or viral or other infectious problems, but we don't want to have our immune system so ramped up that our immune system is attacking our own cells, which is
Right.
what is happening in autoimmune disease, right? And
Mm-hmm.
so, gene that's produced by the immune system to kind of regulate the function of immune cells. And IL-4 is targeted to macrophages. And so a lot of people think that it's maybe something about the interaction between macrophages and T cells in ovarian cancers that prevents the T cells from working. So we can think about T cells are the cells that fight viruses. They're the ones that would be attacking foreign tissue. So like if you had a transplant or a cancer, because a cancer is really kind of foreign tissue.
Yeah.
And so those T cells are what we're looking at to be the primary attackers. The PD-L1, PD-1 inhibitors are basically modulating T cell function. So the cancer has has hidden itself from the immune system by interfering with that system. And the drugs like pembrolizumab, for example, act by basically unmasking the cancer to the T cell, allowing it to see it again. Well, that's not working in ovary cancer, so maybe there's some interaction with macrophages that's preventing that from happening. And that's what the IL-4 is to do, is to kind of manipulate the macrophages and change that balance and allow the PD-L1 release to work
Got
in
it.
kind of lay terms. There are
Okay.
lots of people working on that in different ways. IL-4 is just one way of looking at that. We actually have a researcher here at Vanderbilt, Fiona Yule, um, who's looking at using nanoparticles to
Mm.
manipulate macrophages.
Hmm.
The same concept, just a different thing to use to manipulate the macrophages.
Wonderful. Thank you so much. So, um, you know, we also know that for ovarian cancer, recurrences are just not one time, right? It may happen multiple times. So the cancer is coming back. So tell us why typically multiple recurrences happen. And on the same token, this is also a curious question on our end that if an ovarian cancer survivor, an overcomer, gets diagnosed at an advanced stage, for example, and then for the next decade or so doesn't recur at all. At that point, no, not even a single recurrence. At that point, can we optimistically say that the patient is cured? I mean, what is the chemistry behind the multiple recurrences and then no recurrences at all? What's going on
Well, I'm gonna handle the easy part of that question
here?
first, which is the no recurrence. Um, so, typically we would say for most cancers that if the cancer does not come back within 5 years, that the cancer is cured. But again, we have to think about that there are different cancers and different disorders that have kind of different time frames.
Mm-hmm.
So if we think about two specific kinds of ovary cancer that have, or ovarian tumors that have kind of delayed patterns of recurrence, we can think about, and then we don't usually touch on this, but borderline tumors of the ovary, which are probably precursors to low-grade serous carcinoma that can recur 10, 20 years down the line, and when they recur, can recur as low-grade serous carcinoma. If we think about granulosa cell tumors of the ovary, which again are a very different kind of ovarian cancer than what we normally think about, it's a cancer that comes from the stroma, from the structural component of the ovary. Those cancers also can recur late, 10, 15, 20 years down the line. But for the majority of cancers, and certainly for someone with high-grade serous carcinoma, if they have had 5 years without recurrence of disease, we would consider that person to be cured. Why multiple recurrences? Well, it gets back to the first recurrence. So once we had that tumor cell that was resistant to treatment, that is just a marker for resistance to treatment. So if we think about it, we gave the patient the best treatment we had in the beginning. It might be Taxol carbo, it might be Taxol carbo bevacizumab, it might be Taxol carbo bevacizumab with a PARP inhibitor, right? But in the end, whatever we've given them the best thing we had, and how we choose among those options is very dependent on the patient's particular situation. Giving everybody everything isn't always the best thing to do, because sometimes it doesn't help and may actually cause more complications than benefit. But the bottom line is, given the patient's individual situation, we've given her the best drugs up front. And so if there was, we know that the platinum agents are the most active agents in ovary cancer. So if there was even a single tumor cell that had pre-existing resistance to those agents, then it's going to carry that resistance forward. So even if we get a remission, and it comes back, so remission would mean that all the signs of the cancer are gone. It comes back, that indicates that there's this ultimate underlying resistance. Now, we know that if it's been more than 6 months, and preferably more than a year, since the patient has received their last platinum-based chemotherapy, that a platinum-based chemotherapy combination, again, can be very useful for that patient. But although we're going to get some, although we hope to get some response, about 80% or so of patients will have some sort of a response, perhaps go back into remission again. We know that's not going to be permanent. And even if we do get a remission again, subsequent remissions are going to be shorter than the previous one typically. A lot of our patients have the challenge of recurrence, but they also have the challenge of persistence, right?
Mm.
That they're living with their cancer.
Mm.
And I think that's a huge challenge, to have to live with coming to get your treatment and all the side effects that that has, both physically and emotionally, and the disruption of people's lives. That's a super difficult challenge, and the kind of the knowledge that we're fighting holding action is what I usually tell my patients. We do, on the other side of that coin, we've seen some gradual increase in the median survival for patients with ovary cancer as we've developed better drugs. And hopefully, as we continue to develop new drugs that target new targets, for example, like the folate receptor alpha blocking agents, the ADCs, the antibody drug conjugates, we may continue to see that prolong further.
Thank you. So, um, in terms of the new, again, this is again a new article that I was reading about this new immunotherapy target called the cryptic antigen, that may help prime the immune system against ovarian cancer. So, with so much research ongoing in this particular like uh, immunotherapy sector, how close do you think we are achieving success in immunotherapy in ovarian cancer?
Yeah, I mean, just based on what I know about the work going on with macrophages, I do think that we're probably close to having um, some effective immunotherapy that's probably going to target both T cells and macrophages. The cryptic antigen issue, um, and when I say close, I mean, when we talk about bringing a drug to market, we're probably talking about 5-year time frame, 3 to 5 year
Mm.
time frame,
Mm.
if some of the trials that are going on now really pan out.
Yeah.
We obviously have to see that as they move through the phases, sometimes things aren't as good as we think they are. But
Yeah.
I would hope maybe 3 to 5 year time frame. That might be optimistic, but I'm an optimist. Um, the cryptic antigen issue is interesting because it takes a lot for the T cells to find the cancer cells. And the cancer cells can hide from the T cells in a lot of ways. And the T cell is recognizing some sort of a protein on the surface of the cancer cell that it recognizes as foreign, and it says, "Oh, look, that's a bad thing. I need to go attack it." But sometimes the things that the area on the proteins are really folded up, and can be the area that the T cell needs to see might be hidden
Mm.
inside the folded up part of the protein. And so this idea of cryptic antigens is, how do we get some of these areas that the T cell needs to see to be visible, even though they're inside this folded up protein.
Okay, that's it. That's fascinating, actually. Yeah, thank you. So I think this was a good segue into my next question about the CAR T cell therapy that's ongoing in ovarian cancer. And so I've read a lot about all this. And so can you tell us more about what what is the CAR T cell therapy, and help us understand the profile of the patients that benefit most from it, and what should our overcomers as well as the family members know about asking their healthcare providers as this therapy as an option for them?
Yeah, so CAR T cell therapy was originally developed in like leukemias and lymphomas,
Mm.
where there are very specific markers on the malignant cells. And what they can actually do is take the patient's own T cells out. They make they make this antibody to whatever that, like, CD36 molecule or whatever it is that's on the surface of the cancer cell, and they put it on the
Oh,
T
okay.
cell. They engineer the T cell so that the T cell will recognize this very specific marker on the leukemia or lymphoma cells. And that's really easy in those diseases because they all have the normal cells from which the malignant cells come, and therefore the malignant cells have these very specific markers on them, very
Right.
specific proteins on them that are part of their function in the immune system. So one of the challenges in solid tumors has been, and so what, I'm sorry, so you take the T cell out, you engineer it so it'll see that particular protein, then you give those
Back to the
engineered
patient. Yeah.
back to the patient. And
Mm.
then those engineered T cells go after the cancer cells, right?
Mm.
So I think one of the challenges in solid tumors has been identifying targets, right? Because you need to identify a target that's going to be really only on the cancer cell and not so much on normal cells. It's
Of
like
course.
every other
Yeah.
problem with targeting therapies, right?
Yeah.
And so, there are some different CAR T cell um, um, studies going on at various places. There's one, for example, that I'm familiar with that is looking at a super interesting molecule because it's stimulating hormone, important part of our of how we ovulate every month, basically. And so, these trials are really all very early.
Yeah.
And mostly I think phase one. If there are some in phase two, I'm not familiar with that, but there may be because I can't keep track of every trial at every
Of course.
place.
Yes.
I think one of the biggest things to understand about these treatments is that um, there are some fairly significant potential side effects in how the immune system gets revved up when we do this. And so, I think largely these trials are focusing on folks who are maybe a little younger and maybe a little healthier um, than to be sure that they could tolerate any kind of side effects.
That makes sense.
Um, as with any clinical trial, I do think it's important to, think about practical issues like, I think the follicle stimulating hormone receptor trial, I think is at Moffitt in Florida.
Hmm.
So, if you live in New York or you live in Houston or
Yeah.
Nashville, what is your ability to get there to do all the things that you need to do to make the follow-up visits, to be followed if there are complications or difficulties, right? So that's, I think, always a challenge for many folks to have the psychosocial and the financial support to be able to do that. And so just as in general with clinical trials, to talk to your physician and find out what's available near you, right? In some place that might be practical. I mean, and if you do have the ability to travel and so forth, obviously you can expand your horizons more broadly. But I think for many folks, that's just a true logistical challenge.
Of course. Yeah. Thank you. So, you are doing some groundbreaking work. I was reading about this in developing a desensitization protocol in treating cancer patients with severe drug allergies. And you have made strides on this particular project or the work that you're doing. Tell us how these innovative treatments make such a great difference in the care of such patients, and what is it that you've actually worked on? Please share with us.
Yeah, so desensitization, so allergies, right? Allergies to chemotherapeutic drugs are real.
Yes.
And if you think about our two best drugs, carboplatin and paclitaxel,
Yeah.
are drugs for which it is not uncommon for people to have allergies.
Hmm.
And when I say allergies, I mean true anaphylaxis, bee sting kind of anaphylaxis with carboplatin, particularly on re-exposure. So it's
Mm.
typically carboplatin reactions are unusual during the initial treatment. But what happens is people are sensitized during that initial treatment phase, and then if we re-challenge, if we bring that drug back, a year later when someone has a recurrence, usually not the first cycle, but often the second, patients can have a very, very severe life-threatening allergic reaction.
Mm.
Taxanes are super interesting. So paclitaxel is super interesting because it is a large molecule. It's in a large organic molecule. And so it's not soluble in water. And so there are actually two kinds of reactions we see for Taxol. One is a sort of an anaphylactoid reaction. It's not true anaphylaxis, and it's probably a reaction to the cremophore alcohol
Mm.
that the Taxol is dissolved in.
Yeah.
Uh, Sometimes that can be overcome with steroid premedication. Sometimes that can be overcome by switching to its sister compound, docetaxel. But there is a second set, and this has become known, I think, more recently, of true anaphylactic reactions to Taxol, and it's probably sensitization from different kinds of trees because Taxol was originally derived from the Pacific yew, right?
Mm.
It's a natural compound, and so there are particular kinds of trees that may sensitize people to Taxol, and so there's this other set of Taxol
Mm.
reactions that's true anaphylaxis, which I think we didn't realize until more recently. Kind of bottom line is that those are really important drugs for us, and it's really important for us to be able to give them.
Yeah.
By the way, some of those Taxol reactions happen not when we bring Taxol back, but during the first round, because again, maybe it's to the cremophore alcohol, which is more anaphylactoid. And if it's true allergy that's been primed by exposure to these different kinds of trees, well, you've already had the original exposure. Now you're getting the
Mm.
second exposure with the Taxol. Now, we've known about desensitization for a long time. It's a classic thing that we do, for example, for people who need penicillin.
Yeah.
Um, if someone has a need for penicillin and only penicillin and no other antibiotic is going to work, and there are some diseases for which that's true, then what we know is that we can give people a really, really teeny tiny dose and then just gradually increase that dose little by little by little and kind of fool the immune system and kind of slip it by.
Mm.
The immune system is a magical, wonderful place. But basically just kind of slip it by. And that's what desensitization protocols do. We depended a lot in the past in desensitization protocols for on steroids. And I think what Dr. Stone, and no one should give me credit for this because this is all work really being done by our allergy colleagues. Cosby Stone is one of our allergists here, and Cosby's personal story is that he had a dear friend who died of ovarian cancer. And so he is extraordinarily motivated to help
Mm.
women with ovary cancer get the medications that they need.
Mm.
And so that is interesting in a person who's an allergist, how that comes together. And
Right.
so he has been working on developing these protocols. And honestly, his protocols to me are very interesting because they mostly involve, I mean, there's some steroids involved, but they involve tamping down other parts of the immune system with drugs like certainly classical antihistamines. Those are the H2 blockers, but the other histamine that we don't think about a lot, but we think about with allergies is H1, which is blocked by drugs like Pepsid. And then using things that are used like montelukast that's used for people who have asthma. And so
Mm.
they use these kind of drug combinations to kind of suppress the immune system, really low risk, low side effect kind of medications that patients take before and after. And then there's a protocol that we use, again, that's slipping the chemo by the immune system by giving the teeny tiny dose and then edging it up. We have for people who have severe reactions, we might need to do that over a longer period of time versus a shorter period of time. We were originally doing this only inpatient, and we've learned that for a subset of patients who don't re-react in the hospital, can actually be done safely in the outpatient setting. And so
Mm.
really all credit to Dr. Stone, who's very, very dedicated to our patients, really a champion for them.
Thank you. So, just one follow-up question on that. So, for these teeny tiny doses, as you mentioned, does that then prolong the treatment because it has to be given slower? And does that impact the cancer, like coming, like what I'm trying to understand is if you give a tiny dose when a big dose is required for the cancer to be contained, does that do anything harmful to the cancer growing or not so much?
I'm sorry, I didn't explain that well. So in the end, it's the same dose.
No, I
We're
understood
giving,
that.
Okay.
what I'm asking is because you're giving slow, like little doses, little by little, right? So I'm assuming that, let's say, standard dosing, if it's 10 days, it gets elongated to 21 days in this
Oh, no, no,
procedure, or
no.
does it
Sorry.
not? Okay, okay,
No, no, and that's again, that's where I wasn't clear. So this is all happening over a few hours. So
okay.
you
I see.
start, we have two protocols. There's a two-bag protocol, but and a three-bag protocol. And basically, the first bag has a very, very small concentration that goes in over like an hour. I actually can't remember the infusion times, but that goes over a period of time. And as long as the patient tolerates that, then there's the next bag that has a slightly larger
Got it.
concentration. And that goes in over a period of time. And then again, this is minutes to hours,
Okay.
not over a period of days. And then the last bag is the highest concentration. And then all of this is happening, I mean, within a few hours. This is an outpatient thing. Even if the patient has to come in the hospital to be monitored, we admit them the night before they go home the day of their treatment.
Got
So
it. So
it's a short
yeah.
day.
So it's not really changing the pattern or the timeline for the treatment. It could be just a few more hours that the patient needs to stay in the hospital. Got it. For the
Exactly.
infusion. Okay, thank you
Exactly.
for that clarification. So we also know that, our overcomers typically face this challenge of, okay, the treatment is working and it is shrinking the cancer, but it's also adding those significant side effects to your daily life, where it's hindering. It's a hindrance to your daily activities. So how do we best navigate this scenario and what would be your guidance to our overcomers in situations like these where they don't necessarily want to abandon the treatment that's working and shrinking the cancer, but also having a very difficult time managing the side effects that's coming from it?
Yeah, and that is particularly a challenge to our patients who are living with the cancer, right? Who
Yeah,
are seeing multiple drug regimens, and often
exactly.
these side effects, so we think about things like neuropathy or we think about things like low counts, can be cumulative over time, right?
Yeah, yeah.
And so a couple of things that I would say just generically. One is to be upfront with your provider about the symptoms that you're having.
Mm,
Okay. I think sometimes patients are concerned that if they tell us that they're having side effects, that we may say that they can't have that drug anymore. Right. And there are things that we can do in terms of dose reductions or modifications, schedule modifications, um, medications to manage symptoms or side effects. And so it's really important to be upfront and honest with your provider about the symptoms that you're having.
mm,
Um, I think it's also important to, I mean, I think sometimes both providers and patients get sort of caught up in the sort of tunnel vision of, and I always try to help, or the way I try to think about it is to say we have two things that we're doing. We're treating the cancer, and treating the cancer is very important, but we're also taking care of the patient, and the pain and their cancer things have to be balanced as we make treatment decisions. Um, Sometimes even doctors get tunnel vision about that. And
mm,
so I think if you're expressing concerns about side effects and maybe feel like that they're not being addressed, one thing to do is to request referral to a palliative care doctor.
mm,
And I want to stop here and talk a little bit about palliative care, because I think a lot of people have made the one-to-one correspondence between palliative care and hospice. And that is not true. Okay, that is just not true there. Yes, hospice is a form of palliative care, but palliative care is not all hospice.
yeah,
Okay.
mm,
So we are very fortunate here at Vanderbilt to have a very robust palliative care service who help us manage cancer-related side effects,
mm,
whether that be intractable nausea, whether that be pain, whether that be neuropathy. So we have a partnership with these physicians who have this expertise in symptom management. And as medicine has become more and more complicated, I mean, yes, I manage routine nausea. Of course I do. But when you have the patient who has refractory nausea and vomiting from a chemotherapeutic and the usual things you do aren't working, we do have colleagues who have expertise in these areas and who can help us, right? And so I think, bringing the full team to bear is hugely helpful for our patients. Um, you know, I, I honestly, I used to manage all my own cancer pain. And it's become so complex with so many different drugs and so
Sure.
forth, and regulatory requirements as well. I mean, I don't do it anymore. I refer
Mhm.
patients who need pain management to people who are expert in that, and I assure you they get much better pain management from those folks than they would from me. So I think, if you feel like you have unaddressed symptom issues, maybe asking if a palliative care referral would be something that you might benefit from.
That is such an
And I
important.
think that, oh, so go ahead. I'm
No, no,
sorry.
no. I was just saying that's such an important point that you raised. Yes.
And then the other thing I was going to say is, to think outside the box a little bit about other things that I'm not talking about, things that don't have, I'm a very evidence-based person, okay? So I'm not talking about things that don't have evidence basis to them. But there is evidence, for example, about the benefits of yoga. There's evidence for pain and for neuropathy about the benefits of acupuncture.
Mm-hmm.
So if you are fortunate enough to have access to a, an evidence-based alternative medicine program, we have the Osher Clinic here at Vanderbilt. That's another huge resource for management of cancer-related symptoms that, for example, with the acupuncture, it doesn't work for everybody, but I have a number of patients who I've referred for acupuncture who have gotten really great benefit from that for their neuropathy. So just some outside the box things to think about.
And and that is also very important between the integrative medicine and the palliative care, on top of your traditional medications that you're receiving. That could always be helpful in helping you manage the overall symptoms. So thank you for mentioning that. So, Dr. Crispens, what are some of the recent promising clinical trials that you would suggest our overcomers find and sign up for, and why?
Yeah, well, as you know, I don't ever want to, be the person who's the advertisement for one particular trial over another because, that just makes people mad. Uh,
Sure.
um, But I think, again, thinking about the things where we're really looking to make progress are immunotherapy trials and are antibody drug conjugate trials. So we have some trials moving forward in the antibody drug conjugate space, trials that we've already talked about, a number of immunotherapy approaches that people could think about. And again, I always also just want to say, please think about, what also will work for you. I strongly encourage patients to participate in clinical trials throughout the lifespan of the cancer, right? From the very beginning. If there are trials open to you at the initial diagnosis phase, if there are trials open to you in the prevention phase, if there are trials open in the recurrent phase at where you are or near where you are, to think about those. Um, I think we've talked about a lot of those things. Again, kind of excitement on, is it an antibody drug conjugate using a traditional payload? We know that antibody drug conjugates have a limited number of payloads. Mostly in ovary, we see topoisomerase inhibitors and microtubule toxins, but the payload is responsible for a lot of the toxicity. So something to be on the lookout for example, would be not just a different target, Not just a different molecule that's being targeted on the cancer cell, but maybe a different payload that might have less toxicity associated with it. And again, some of these trials, whatever it is, whether it's IL-4, whether it's nanoparticles or whatever it is, trials that are looking to target macrophage activity, as a way of trying to help the T cells be more active in immunotherapy. So I would be looking for those sorts of trials are the things that are really kind of, I think, exciting right now.
Okay, so I will also ask you this, that we know that we there is this initiative for the reduction rates in the administrative costs for clinical trials, etc., versus what it was before, the direct and the indirect costs that the federal government is kind of regulating right now. So, what are your thoughts on its impact on advancing research and science as we see today?
Yeah, and so first, I want to make this non-political.
Of course. Yeah.
I'm not endorsing one political party or another, or one political approach or another. I'm speaking only related to the idea of what's what what's best for our patients,
Yes.
right? Um, and I think one thing that we don't know is we don't entirely know where all this is going, right?
Mhm.
We don't know where the final endpoint will be. But we have seen, so basically, just to kind of explain maybe a little bit about what some of this means, right? Because I think these are things that maybe lay people are less familiar with. So when you're doing a basic science study in the lab, like you're trying to find a new molecule, or you're trying to find a new strategy to approach ovarian cancer in the lab, maybe in a test tube, maybe in mice, you write a grant and you say, this is what I propose to do, and this is why I think it might work. And that's reviewed by experts in the field. And if you get that grant, you've made a budget, you've sort of figured out how much you think this is going to cost, right? And so that budget that you've made is going to pay for your part of your salary, whatever percent of your salary is you're going to be devoted to this grant. So let's suppose you're 50% clinical and 50% of your time is devoted to this grant. And there are actually caps on the amount of money. It's not like people are making $500,000 on a grant. No, they're not, because there are big caps on how much money a researcher can make. And in fact, I have a 50-50 person in my division, and that's a serious issue for her because she's paid less than my full clinical people
Yeah.
because of that cap, right?
Mhm.
So she wants to do research. She's dedicated to this idea of doing research. So there's that part of the money. That's what we call directs. Those are the costs that go to the researcher to pay for her time, his or her time, and pay for the lab tech, and pay for the mice, and pay for the reagents, and the cells, and all the things. Okay. But then there's something called indirects. Indirects are paid to the institution because, well, there's a lab. And so that lab is in a building. And that building has to be maintained. And we have to turn on the heat. And we have to turn on the lights. And we have to pay somebody to clean, right?
Mhm.
And we have to pay maintenance to keep the lights on, right? So that's what's called indirect costs. What has happened to this point is that um, we've seen a 50% reduction in indirects
Mhm.
to researchers. And that has made, I think, researchers and institutions concerned about their ability to continue to do certain forms of research that might have, fairly intensive costs around maintaining infrastructure,
Right.
right? So think about maintaining an animal facility, for example.
Yeah.
That's pretty costly.
Mm.
I know some people might be averse to animal research, and I apologize to you for that. But there is an infrastructure cost to that, right? Um, so there's concern that certain types of research may be more limited or impossible to do, or that certain institutions may look away from some types of research because they may not be able to afford to do them. Some
Yeah.
institutions have deeper pockets than others, right? Harvard has a huge endowment, some places don't.
Yeah.
So there's concern there. I think we also just don't know what's going to happen on the clinical trial front in terms of government-supported, NCI-supported clinical trials,
Mm.
and whether we're going to have the infrastructure to continue to do those trials, how the cuts are going to affect that, to be able to do those trials safely and effectively and get the data and, do the things we need to do to take care of patients. It may be that people don't value that, and if they don't value that, that's okay. Your values are your values, and I accept that. But I think that if you are someone who values trying to make progress in cancer research, whether it's ovary cancer or prostate cancer or whatever
Mm.
cancer we want to talk about, yeah, I would just encourage you to, speak up to your representatives in Congress and the Senate, to whomever, to advocate for what I think are important things. I mean, we have made tremendous progress
Yes.
in my
Mm.
lifetime. Okay,
Yes.
I am not that old.
Yes.
Um, in my lifetime, we have gone from I was a resident when the trials of Taxol, when GOG 111 was being done. I was a resident and saw ovarian cancer treatment revolutionized by the introduction of Taxol.
Mm.
Okay, that was when I was a resident at UAB, and I used to go see it was 24-hour Taxol. We had to have the patient in the hospital on a monitor, and it was very different than it is now. And I used to go see those patients in the middle of the night when they had problems, right? But it was exciting because here was this new drug that really changed the landscape.
Mm.
And yes, it is the case that certainly drug companies, pharmaceutical companies perform research. But I think that I would be worried about um, having the only source of research be pharmaceutical companies. Not
Mm.
because I don't believe that they're not trying to do the best that they can, but because I think that there's just a different when we have this we have a when what you're doing is for the greater good, right? There's just a different tenor to what you're doing and how you're doing it than when you're doing it for profit. And both have a role. We wouldn't get drugs to market if
Absolutely.
we didn't have pharmaceutical companies, right? And I
Absolutely.
respect my pharmaceutical colleagues, right? And they are also trying to do great work. But I think we need both sides. I don't think we can survive without one or without the other.
Mm.
Okay. And I think our ability to make progress in treating and curing cancers is going to suffer if we don't continue to support our investigators at our academic institutions and our investigators who are writing and conducting clinical trials through the various NCI methods. It's a
Thank,
personal opinion, but share that opinion. I would urge you to reach out to your congressman, to your senator, let them know what you value and that you would hope that they would continue to support these projects.
thank you, Dr. Crispin. That was such a thoughtful and well-crafted answer. I thank you for that. It was very well uh, described and clarified. Thank you. So, you have taken care of patients for so many years, but upon getting diagnosed or while experiencing a recurrence, what questions do you wish your parents asked you, or even the providers would provide them with the answers for? What do you wish they would ask you?
Yeah, and I think that having done this for a while, I sort of honestly try to anticipate and provide that information, but I think that it's really important. Getting a diagnosis of cancer is overwhelming. Okay.
Mm.
So your first visit, I think one of the things to understand is that this is going to play out a little bit over time, right? So your first visit is literally drinking from the fire hose of everything, right? And so I absolutely empathize with wanting to know everything from minute one, but also would, maybe suggest that you can't take it all in. It's not possible. And so to understand that this is going to be a process, and that even if we say everything in the first visit, you're not going to hear half of it, maybe more than half of it, right?
Sure.
Because it's
Yeah.
just so overwhelming. Having people with you helps, taking notes helps, having access to the physician's notes in electronic medical records helps, but having this sense that this will evolve a little bit over time, and not over infinite time, right? But having the sense that this will evolve a little bit over time and continuing to have conversations beyond the first conversation. I think that's where maybe sometimes we fall down, is not continuing to have conversations after the first conversation, because it's always interesting to me what I know I said, but what then when you get teach back, you find out the patient heard, right? And that
Right.
might be teach back at a second or a third visit, right? And then understanding that it's as your disease, uh, as the process of you having this disease unfolds, that things are going to change and you're going to learn more, and things that you're going to need, again, that unfolding of information over time. Because what I say to somebody at recurrence is very different than what I say from the beginning. Although I will be honest with you, I tell people from the beginning there's a likelihood of recurrence.
Mm-hmm.
And then I think, you know, it's really hard to hear that, but being open to receiving that information is important. I think the people who, and I think it's easy to want to maybe put your head in the sand or have some denial or not want to know kind of all the bad things. And I'm not saying that we're going to like tell you all these horrible things, right? That's not
Yeah.
appropriate either.
Yeah.
But just having some general idea about prognosis from the beginning, I think, is important, and being open to listening to that. We're not trying to take away your hope, and hopefully this is happening in a gentle and appropriate way, right? Because we shouldn't just be hammering you with
Sure.
news, right?
Yeah.
But this balance between understanding that things will unfold over time, having some honesty from the beginning, and then so that you can trust and partner with your provider, because that's who we are. We're your partner, right? We're here to help you make decisions, follow treatment plans that are right for you. It's not one size fits all, for sure.
For sure. Thank you so much. So, one question I had about PARP inhibitors, that right? So, because like you said, they have been one of the magic drugs of ovarian cancer that we have come across in the recent years. However, the guidelines for the PARP typically is 2 years, and then you don't do that anymore. However, we do. uh, I recently have spoken to a few, and we have experience talking to overcomers that have been on PARP for more than 2 years, maybe five, seven, longer amount of time, but they are doing phenomenally well. And then there are overcomers who are a little, um, what's the word I'm looking for? They're unsure about getting off of PARP after 2 years because it has worked for them so well. So, what is this difference between happening between the guidelines and for some patients it is really working beyond 2 years without any toxicity? And based on this, what is your general guideline for our overcomers who've been asked to step off of PARP after 2 years?
So I think that's an interesting question. I think, in G1 oncology, we're actually looking at it from the other perspective, which is, can we shorten it? That's being looked at. Do you need 2 years? Is
Yeah.
1 year enough? Is
Okay.
a shorter period of time enough? So I think one of the things that it's really hard for everyone, doctors, patients, everyone, to get their heads around is more is not always better.
Mm.
Um, I'll give you a concrete example from G1 Oncology. We know that if you have locally advanced cervical cancer and we do a radical hysterectomy and that has to be followed by radiation therapy, well, gosh, seems like more should be better. And it turns out, if we compare that to just treating with the same radiation therapy, it turns out that radiation therapy has the same outcome as
Mm.
doing a surgery and radiation and fewer side effects.
Mm.
So More is not always necessarily better. We know from trials in ovarian cancer that 8 isn't better than 6, 12 isn't better than 6 when we think about your initial treatment, right? More is not necessarily better. At some point, we've reached the maximal benefit of a particular drug.
Mm.
And I think that knowing that intellectually, but then the idea that this medicine must be what's keeping my cancer away
Yeah.
emotionally, right? You're
Yeah.
emotionally attached to that, and it's very
Mm.
fearful. There's a lot of fear associated with giving that up. But I think we don't have evidence that 5 years is better than 2, that 3 years is better than 2. It's interesting that olaparib and niraparib had different trials, and the niraparib trial was 3 and the olaparib trial was 2, right?
Mm.
Um, but again, there's not really evidence to support that longer is better. And for patients who do well, I understand again why they'd want to hold on to that. But overall, we know that these drugs do have side effects, including a risk of inducing pre-leukemia and leukemia. And the drug-induced pre-leukemias and leukemias are often not particularly treatable, unfortunately. And so I think, we always have to balance risk and benefit. And right now, I understand the emotional attachment. I understand the not wanting to give up on the maintenance. We don't just see this in PARP. We see it with, in endometrial cancers, you get patients who get treated with pembrolizumab. There's a limit to that maintenance therapy, right? And patients are, well, but why wouldn't I continue? Right. But we just don't have evidence always that more is better.
Thank you, Dr. Crispin. So, you have taken care of patients for 3+ decades now, right? So, what keeps you inspired and motivated to gift us the hope for a better tomorrow?
Yeah. So I just think that my patients are beautiful people, and they teach me so much every day about how to be a good person and how to live a beautiful life. And I've always, some of my patients will not survive their cancers, and I know that, and they know that. But I've always felt that it's been a privilege to walk with them on their journey, whether we have the outcome that we would hope for or not. Um, and sometimes it can be challenging emotionally. I'm going to acknowledge that. Um, and but in the end, it is a privilege to be able to participate in these people's lives.
Thank you. I saw it on your face as you were giving me the answer. So we have talked about a lot of things, Dr. Crispins. What have I missed asking you that you would like to share?
Um, so I'm going to turn it around and I'm going to ask you, what do you hope for? What do you hope for your group and for all the people who work with you and all of your overcomers? What is your hope or dream? Why do you do this?
So, you know why I do this, but my hope has never changed from day one. Is my hope is to shut down, overcome as soon as possible because we have found a cure for ovarian cancer. That is my hope. I mean, there is no reason for me, I will continue to, as you know, I'm passionately dedicated and committed to the community, but my hope is that we don't hold these talks anymore because we have found a cure and there is no longer ovarian cancer in this world. That's my hope.
I share that hope with you.
I know that you do. Thank you. So, Dr. Crispins, before we are this has been a great conversation as always with you. But before we sign off, what message of overcoming would you like to share with our overcomers listening today?
Well, as I think I've said before, is to continue to have hope, right? Because the science is changing and the science is moving forward. And we have drugs today that we didn't have 5 years ago. We are seeing things get better. We are seeing progress being made. And so to try to continue to hold on to hope.
Thank you so much, Dr. Crispens. I mean, the past hour we had so much that we talked about, but I feel like, as is the case always with you, I could go on asking you questions. Thank you so much for your time and your invaluable knowledge that you shared with us today. And overcomers, hope you enjoyed this episode of Connect Over Coffee with Dr. Crispens. And as I always say, please share this video far and wide with anyone who may benefit from all the wisdom and the insights and the incredible knowledge that Dr. Crispin shared with all of us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.